So today we'll discuss about the basics of epidemiology, basics of mortality and morbidity, how do we say, and the basic structure of the different important study designs and the output, right? So these are the things that we will cover today. The epidemiology, the word, it has come from three Greek roots. One is the epi, that is upon or among, demos, that is means the people or the population, and the logos, the study or the discussion. So anything that are studied among the population or with the population, they are basically known as the epidemiology, right? So it is on the population level. Now, if we think about our scientific studies, so it can be approached at 4 different levels. So one is the submolecular or molecular level, right? So whether cell biology, genetics, department of biochemistry, pathology, immunology, they are all involved with this, with the motto, they act on the submolecular or molecular level, right? Next, if you think about some broader version, next is the tissue level or the organ level. So basically the people of anatomy, people of pathology, so the anatomic pathology, their domain is to work on the tissue or the organ level. Now, if you think about still broader perspective, then it will come at the level of individual patients. Basically all the clinical medicine department, medicine, surgery, gynae, pediatrics, psychiatry, right? So all the departments, they are working on these things, level of individual patients. So different patients, they are coming in the either IPD or the OPD, and from there they are getting their treatment. Now, where do we stand? Now, when we think about something much broader than the individual level patients, we think about the level of population. It is basically the domain of epidemiology. Now, is this clear to all of you? Now, if you think we have started with the molecular level, then we came to the tissue level or organ level, then we came to the individual patient level, and then much broader perspective is the level of population when we talk about the epidemiology. Is this clear? So please remember, so epidemiology deals at the level of population. Clear? So this is the person, his name is John Murray Lust. He actually one of the father of the present epidemiology in the world. Just 2 years back, he has passed away at the age of 92 years, right? So next, say for example, I'm telling you that I have come from a village, and from my village, in the last 2 months, I have noticed several food poisoning cases, right? So this is the statement that I'm making in front of you. So I am coming from a village of Kolkata, or say for West Bengal, and in the last 2 months, I have noted so many food poisoning cases in my village. So this is the statement that I have given to you. Now from this statement, what are the different questions that come in your mind? So it will be interactive session, right? So that all of you will not sleep in this chilly weather, right? So it will be discussion mode. So anything. So what do you think? I'm telling you, in my village I have noticed so many food poisoning cases. Now from this statement, what are the different queries that are coming in your mind? What madam has said, what is the source of the drinking water? Okay.
So the people died, what was the age group?
What she is telling, people died, what are the age group? I'm not telling died, so whatever she is telling, how many people were affected, their age group. Good.
Population in that village, number of food poisoning cases.
She is telling much more important thing. She is telling, sir, in your village, how many populations are there? And out of how many population, how many they were involved or affected? Very good. Anything else?
So was there any celebration or gathering?
Very good, very good. Was there any gathering or nothing? Huh?
Hygiene.
Hygiene. Okay, good.
Outcome, like they recovered or they anybody.
Very good, excellent. So you see, these are the different questions that will come in our mind. So I'm just telling the questions what you have told, what she has said. She is telling, sir, in your village, I don't know how many people are there. Out of how many people were affected. So this is basically the frequency. So whenever, first and foremost, whenever one epidemic or any outbreak or any pandemic that is reported, our first intention is to find out the frequency. Out of how many were affected. So this is the frequency. Very good. Now she has said, I want to know the distribution of the affected person in terms of age. She is interested to see whether more extremes of age groups are involved, pediatric or geriatrics, or most the middle-aged people are involved. Or in terms of, some might ask me, sir, what are the gender distribution? Whether males or females were more affected. What are the distribution according to the socioeconomic status? Whether lower socioeconomic status people, they were affected more. So this is all what I am telling. This is all distribution. Distribution of person. Distribution of person. So first we talked about the frequency of the disease. Second one, we are talking about the distribution. So whenever we talk about the distribution, we talk about again three important aspects: place distribution, person distribution, and the time distribution. So whenever we are talking about the distribution, so all discussions that are going on, these are basically the person distribution. Isn't it? All person, age, gender, socioeconomic status, etc., etc. Now, if I talk about the place distribution, I have told you I am coming from a large village. So you might be interested to know. Suppose this is the map of my village. So now you are interested to know whether food poisoning cases were reported throughout uniformly from the village, or some pockets were there. Here more, here more, here more. So this is known as the place distribution. So this is also very important. You might be interested to know. And the next one, third one, you might be interested to know. Since I have told you there are a large number of food poisoning cases in the last 2 months, then again you might ask me another important question. Sir, whether in the last 2 months uniformly cases were reported, or more cases were reported in the first month and the second month, or is there anything? Isn't it? So this is basically known as the time distribution. So we have talked about the frequency, we have talked about the distribution. And third, madam asked me, what is the reason? She asked me, what is about the hygiene? So what is this? These are basically the causative factors, precipitating factors, aggravating factors. These are known as the determinants. So please remember, whenever we talk about the epidemiology, we talk about three important components of epidemiology. So one is the how many. So this is basically the frequency that is represented by either rate, ratio, or proportion. So these are the three different tools we are having in epidemiology, by means of which we actually give the output of the frequency. How many? How can we say? We can say either by attack rate, we can say by the ratio, or we can simply say about the proportion. What is proportion? Prevalence is an example of proportion. Out of this much were affected, this one by this one into 100. So expressed in percentage. So this is the prevalence is the proportion. Whenever we talk about the ratio, incidence is basically a ratio, right? Sorry, incidence is not the ratio, something else is ratio, and I will come to you later on. Is this clear? So whenever we talk about the frequency, this is the first component of epidemiology. This is expressed in terms of rate, ratio, and proportion. Next important term is the distribution. I have already discussed you. We can say it either in three ways: time distribution, place distribution, and the person distribution. Last but not the least, it is the third component of epidemiology. It is the determinants. Determinant means we are interested to investigate what are the reasons behind, what are the causative factors behind, what are the precipitating factors, aggravating factors behind. That we generate by using different types of studies. We can also see the different types of distribution by some simple study like descriptive studies. But again, the next level of studies like cross-sectional studies, case control studies, cohort studies, randomized control trial, etc., etc. From these studies, we can have an idea about the determinants of the disease. So what are the precipitating factors? What are the aggravating factors? What are the causative factors? Is this clear to all of you? So this is the three components of epidemiology. One is the frequency, second one is the distribution, and third one is the determinants. So different tools of measurements of epidemiology, there are basically, we are having three tools. One is the rate, like incidence rate, incidence density, we'll discuss. Second is the ratio, like relative risk, odds ratio. You have heard all these things, we will discuss a little bit. And third one is the proportion. So prevalence is the proportion. Attributable risk is also measured, it is also proportion. So prevalence, it might be point prevalence or it might be period prevalence as well. Right, so these are the different tools in measurement in epidemiology. So one is the rate, one is the ratio, and third one is the proportion. So what is rate? Whenever we talk about a rate, say for example, what is the incidence rate? Can you tell me how do we calculate the incidence rate? Suppose I am telling you, I am giving you one example. Today, suppose there are, in this classroom, there are 30 participants. In these 30 participants, I have measured all of your blood pressure. I have measured all of your blood pressure today. Today is 3rd January 2023. So I want to calculate the incidence rate of hypertension in the class. Is it possible? Okay, leave it incidence rate. Say for example, I want to calculate the rate. How can we calculate a rate? Say for example, prevalence rate. Prevalence rate when the multiplier is 1000. Say for example, out of 30 participants in the class, 5 participants, they are having high blood pressure. So how do we calculate the prevalence rate per 1000? 5 divided by 30 into 1000. Right. So whenever we talk about a rate, basically there are 4 components of rates. What is that? One is the numerator. One is the numerator. Numerator means those who are having the event of interest. In this classroom, I am interested to see how many of us are having high blood pressure. So high blood pressure is my interest. So numerator is number of persons who are having high blood pressure. So these are the numerator. What is the denominator? Out of the total. Right. And third one, we are having one multiplier as well. Here it is, suppose it is 1000. So this is the multiplier. And another important thing is there, that is the time specification. If I tell you after some period of time, do you know I went to 𝐕𝐢𝐬 and I measured the blood pressure and I saw the prevalence rate of blood pressure is this much and this much. Then you might ask me, sir, at what time you are talking about? At what, it is before COVID or after COVID, before independence or after independence? So many questions might arise, isn't it? So the fourth component is the very much important, is the time specification. So please remember, whenever we talk about the rate, there are 4 components. One is the numerator, second one is the denominator, third one is the multiplier, and fourth one is the time specification. Clear? So in rate, we see if it is multiplied by 100, then we call it as a proportion, right? So in rate, basically the multiplier is either 1000 or 10,000 or 1 lakh. Do you know why do we select this type of multiplier? The answer is only one, just to avoid fraction. When I was an MBBS student in the year 1995, at that time maternal mortality, it was expressed in terms of per 1000 live birth. But now gradually the maternal mortality is decreasing. Now it is being expressed per 1 lakh live birth. So now the multiplier is 1 lakh. Why? Because just to avoid a fraction, so that we can have a manageable whole number. If we have a manageable whole number, then it is easy to interpret, easy to understand, easy to visualize. If I say, do you know the rate is 0.003 per 1000, then you have to think something like this thing. But if I say instead 3 per 1 lakh, then now you can visualize and you can understand. So in rate, we generally select the multiplier on higher side just to avoid fractions, so that we can have a manageable whole number. Is this clear? So this is all about the rate. So attack rate of food poisoning. So this one, the common very rate we calculate in this thing. So specific death rate due to food poisoning. This is also one of the rates that we calculate, right? Next, tools of measurement is the ratio. What is ratio? Division of one quantity divided by division of one quantity. Say for example, in our country, the male-female sex ratio, male is to female. Total number of males divided by total number of females. RBC, WBC ratio in our blood. Total number of red blood cell count divided by total number of white blood cell count, right? So these are all examples of the ratios. So relation in size between two random quantities. Numerator is not a component of the denominator. Please remember, this is very important. In rate, if you think about the rate, you see numerator is itself a component of the denominator. But here you see, whenever talking about total number of RBC divided by total number of WBC, RBC, WBC, they are not related with each other. When we talk about the doctor population ratio, all doctors are taken and all populations are taken without the doctors. So division of one number by the division of another number. So naturally, numerator is not a part of a denominator. So please remember, this is one of the important points in the ratio. Male-female ratio, case fatality ratio as well. This is somehow controversial. I'm not going into details. So that can be discussed later on. Third is the proportion. When in proportion again, the numerator is a part of the denominator. But here the multiplier is 100, right? So that it is expressed this thing. So relation in magnitude of a part of the whole. Say for example, I am interested here to calculate how much proportion of the participants in this class they are having fever. So say for example, out of 30 participants, 3 participants they are having fever. So 3 by 30 into 100, isn't it? So in that way we calculate the proportion. So please remember, here also, just like rate, numerator is a part of a denominator. It is expressed in percentages. Is this clear? So what is numerator? Numerator is basically the number of times an event has occurred, isn't it? So numerator is the number, the event which we are interested to calculate. And next is the denominator. So please remember, denominator, it might be of two types. It might be related to total population, or it might be related to the total number of events. Say for example, I am telling you, in a village, out of how many people they died from food poisoning. So number of people died from food poisoning divided by total number of or the total population. This is basically the rate, where the denominator is total population. Now if I tell you, in that village, around 100 people, they attended one gathering and they took some food, and out of 100 people, 50 people fell sick. So now the denominator is becoming 100 because they only attended the event. Remaining people, they did not attend the event, so they were not considered in the denominator in the calculation. Is it clear? So denominator, it might be related to the total population, or it might be related to the total number of events. Is this clear? Next is the concept of mortality and morbidity. So different mortality rates, we will not going into details. I will just show you, because these are all relevant when we talk about the different study designs, right? So that is why I will tell. So one is the crude death rate. Can anybody tell me why it is known as crude? Do we calculate it very crudely or casually? Why it is crude?
Casually, it's total number of deaths.
So what is the numerator here? Numerator is number of deaths during the year divided by mid-year population into 1000. Why we call it as a crude? Because it lacks comparability. Because say for example, in a particular village, there are two villages are there, village A and village B. In village A, we have calculated crude death rate, and in village B, we have also calculated the crude death rate. Now if I see the crude death rate is higher in the village B, then we might say, see sir, mortality risk is more in village B. That we can say. But now someone of you telling, sir, did you notice that in village B, more number of old people are there? And this exaggerated mortality, these are coming from the deaths of the old people. Then how can you say the risk is more in village B? So this is the limitation of the crude death rate, because it is taking mid-year population. Right, so it is not stratified by age group, it is not stratified by sex group, etc. Say for example, in one of the remote villages, say for example, you think about one of the remote villages in our country where maternal and child health services are not so good, and we are unfortunately losing so many mothers, pregnant mothers. So there in that village, if we calculate the crude death rate, we will see the mortality rate is more in that particular villages, and most of the deaths, these are attributed from the deaths of the child and deaths of the pregnant mother. So these are the things that are not taken into account when we calculate the crude death rate. That is why it is known as the crude death rate, because it lacks comparability that differ by age, sex and race, etc. Is this clear? Next important thing is the specific death rate. How do we calculate the specific death rate? Say for example, if we talk about the specific death rate of tuberculosis in Benares, then what is the numerator? Numerator is total number of people of Benares who died from tuberculosis. This is the numerator. And what is the denominator? Denominator is the total mid-year population. Please remember, it is not the total number of TB people who are affected. So this is one of the common mistakes what we have seen. So please remember, total number of deaths due to tuberculosis divided by mid-year population, just like crude death rate. So when the denominator is this one, so and the multiplier is 1000, then we get the specific death rate due to tuberculosis in one particular place. Clear? Next, specific death rate for male. Next, another important thing is the case fatality ratio. Case fatality ratio means, say for example, in a particular area, there are 50 patients of tuberculosis, and out of 50 tuberculosis patients, 10 patients they died. So 10 by 50 into 100, this is basically case fatality ratio. Clear? And when this is the mid-year population, it is becoming the specific death rate. Is this clear? So this is the thing that you have to remember. So case fatality rate, so it indicates the killing power of a disease. You see, out of there are 10 people, those who are suffering from tuberculosis, and out of 10 people, 3 people they died from the tuberculosis. So it indicates the killing power of that particular disease. So this is how we calculate. Numerator is total number of deaths of patients due to tuberculosis and divided by total cases of the same disease. So total number of tuberculosis patients, multiplier is 100. So it is expressed in percentages. Next, another two mortality rates, I am not going into details. One is the proportional mortality rate and second one is the standardized mortality rate. I am just giving you the idea how do we calculate the standardized mortality rate. Say for example, I am talking about two hospitals, Hospital A and Hospital B. In Hospital A, yesterday, that is on 2nd January, out of 10 pregnant mothers in Hospital A, out of 10 pregnant mothers, 5 mothers they died in Hospital A. And in Hospital B, out of 10 pregnant mothers, only 3 mothers died. So this is the statistics. Is it clear? Hospital A, 10 pregnant mothers who were in labor, out of them 5 mothers, they unfortunately died in Hospital A, and with the same number, same 10 number in Hospital B, only 3 mothers died. So which hospital is doing good? So naturally the answer is B, if I tell this much. But now if you post-mortem, then I am telling you the post-mortem story. In Hospital A, out of 10 pregnant mothers, 7 mothers were high-risk mothers. And 3 mothers, they were not so high risk. So in Hospital A, they could save all the 3 low risk mothers and they could save 2 high risk mothers as well. But 5 high risk mothers, they unfortunately died. But now if you talk about the Hospital B, there were only 2 high risk mothers, 2 of them died, and 1 good mother who were not high risk, she also died. So that is why it is 3 out of 10. Now which hospital is doing better? So the answer is A. So this is the beauty of standardization. So whenever we talk about the standardized rate, we take into account this stratification. So with a single comment we cannot make this one is doing good, this one is doing bad, right? So you have to see. So whenever we have stratified, so this is basically the basic concept and understanding behind the standardized mortality rate.